So next up is Professor Claire Hogg, Professor of Practice in Paediatric Respiratory Medicine at Imperial College London and Clinical Director in Respiratory Paediatrics at the Royal Brompton. Professor Hogg has expertise in diagnosing and managing children with primary ciliary dyskinesia and works closely with other ciliopathy services. And many BBS patients have been referred to Professor Hogg, who has joined us today to discuss the clinical presentation, diagnostic pathway and management strategies of respiratory symptoms in patients with BBS. Thank you so much for joining us this morning. Claire, I'll hand over to you.
Thanks, Tanya. Well, thanks for inviting me along. It's really nice to come, and I caught the second half of Phil's presentation, which is great, and great to see you with a beard there, Phil. It's obviously been a while since we've met up. But I work at the Brompton, as Tanya said, and my specialism is primary ciliary dyskinesia, which is one of the motile ciliopathies. But we've worked closely with Phil and other specialists in the primary ciliopathies because of this link with some patients who have a primary ciliopathy also having respiratory symptoms. And so they come to us for diagnostics. So perhaps if we can just go to the next slide, please. See if that works. And that's the trouble. If it doesn't go into slideshow, you get all that background noise. Is it? And it won't let you, will it?
No, this is grayed out for some reason. Let me try and get rid of this text.
But also, can those videos work at the bottom? If you click on the arrows, so you might have to do that sequentially. I thought it would be good to just start with looking at the cilia structure and function, and looking at the difference between the motile and non-motile cilia. So the two pictures on the left, which if we can just click on the videos, you'll see the different beat patterns there. The one on the left is the airway respiratory epithelium, and you can see it's covered in hundreds of motile cilia that beat in a very synchronized way and clear mucus and debris, infections, etc., out of the airway. And that's a very effective primary defense mechanism in our lungs. And so in primary ciliary dyskinesia, when there's a breakdown of that function, then, that looks better. Not sure. When there's a breakdown of that function, then you get the clinical picture of primary ciliary dyskinesia. In the middle there, you can see the cilia going round in circles. These are also motile cilia that we have in our embryonic node. So these cilia have to function in order for us to have normal organ situs, and in some situations, normal organ function and structure. So when the cilia in our embryonic node during our development from an embryo through to a fetus, through to a healthy baby don't work, you sometimes find that in around 50% of patients, the organs are in a mirror image, so they're in the reverse order, or they can be in a very ambiguous situation. So you might have your heart on the other side, but your liver in the middle. You might have absence of some of your organs, such as the spleen, and then you might have problems such as polysplenia. So all of these things are quite important for our normal development. And then on the right, you can see that's a scanning electron micrograph. There's no video for that one, of a primary or sensory cilia, which we have about one. We have one on many tissues within our bodies, and these have sort of sensory and signaling functions, and they're very important. And the mutations for the primary cilia impact those particular cilia. So as you can see at the top, we have, I've put in a sort of schematic of the different structures of what those would look like when we look at them using electron microscopes. So can we go to the next slide, please? So I just wanted to just give you a little bit of background about primary ciliary dyskinesia. This is probably one of the best understood motile ciliopathies. It's not nearly as rare as the syndromic or primary ciliopathies, and In fact, the prevalence here is the most recently published data of 1 in 7,500 is probably an underestimate. We think it's much more common than this and is probably going to approach close to 1 in 5,000, maybe even a little bit more than that. We have a lot of undiagnosed patients with primary ciliary dyskinesia in adult bronchiectasis clinics still. It is multi-system. It's mostly autosomal recessive in its inheritance, which means the parents would be carriers but not have the condition, as you know. But we have X-linked and autosomal dominant varieties, very heterogeneous, with over 50 known PCD mutations to date. But we can still only really confirm a genetic diagnosis in around 3/4 of patients. And a little bit like Bardet-Biedl, there is a common clinical phenotype in these patients, albeit with a spectrum of severity. Oh, we've gone back to the first slide. But those common clinical presentations would be otosinus disease, chronic obstructive lung disease with a nasty cough, wet cough, often leading to bronchiectasis, which is scarring in the lungs, impaired hearing, fertility problems, and there may be some more syndromic features with some of the mutations, such as hydrocephalus or visual defects, and additional fingers and sensory neural deafness as well. I've gone back to the title slide, Tonya, so I don't know whether you can now get me to slide 4. No, that's it. So in contrast, this is a scanning EM of the primary cilia, as you saw on the first slide, and then at the bottom, that's a scanning electron micrograph of what the cilia within our airway epithelium look like. And you see there are hundreds of these on each of the airway epithelium cells, and they have that very synchronized beat pattern. The different function for the primary cilia, as you can see, and I think you've had quite a lot of discussion of this when I've been watching the previous talks, but they are very important in terms of their sensory and signaling functions, as you are aware. And so the mutations, the genetic mutations that infer Bardet-Biedl or other ciliopathies obviously cause quite a complex array of clinical symptoms. So if you go to the next slide, please. And a little bit like primary ciliary dyskinesia, there are these predictable group of syndromic malformations that I know you've already been through today. Polydactyly is a really interesting one that we often see patients who have a history of polydactyly because they might have had the extra digit removed. But patients coming to us who may not have other syndromic features but have chronic respiratory features with a history of having an extra digit always raises our curiosity as to whether this could be related to a defect of the cilia. So I think when we see, because we know that there is a little bit of an overlap between these non-motile and motile ciliopathies, we're now very interested in asking some of the questions such as, is there an issue with developmental delay? Are there any visual defects, any eye movement defects? We always have these patients have audiology, not just to look for middle ear disease, which is very common in primary ciliary dyskinesia, but also, is there a coexistent sensory neural deafness? Obesity has already been talked about, and other issues such as skeletal dysplasias. So we have several patients in our clinic with short-limb dwarfism, skeletal dysplasias that actually are ciliopathies, and they have a coexistent respiratory cilia defect as well. And we're going to go on and talk about that. So next slide. I think you've missed one, actually. There was one just above. You'll all be aware of these organizations, the Ciliopathy Alliance, but we have patients from all of those groups on the right in our clinic with coexistent respiratory ciliopathies. I'm actually not going to use a patient with Bardet-Biedl as a case study now, partly because obviously it's important that we don't sort of divulge that in a group of lots of patients, I thought it would be better to use a patient with a different primary ciliopathy who would have a very similar presentation in terms of the diagnosis and what we find within the respiratory cilia. So if we can go to the next slide, this family have kindly given me permission to present this case. This was an 8-year-old boy who is now about 14. He's from a highly consanguineous family and had dysmorphic features, developmental delay, and a long-standing history of very unsafe swallow and gastroesophageal reflux with chronic respiratory symptoms. And I think his symptoms had always been put down to being related to aspiration. So he was aspirating liquids and foods into his lungs, and this was causing his chronic wet cough and breathing problems. Next slide, please. He had quite typical features. This is not the patient, this is a library picture, but he had typical features. He'd had extra digits, which had been removed, hypertelorism, which is wide set eyes and low set ears, and this typical triangular mouth. He had astigmatism and some nystagmus, sort of abnormal eye movements. So next slide, please. So because of his dysmorphic features and the consanguinity, which is the intermarriage within his family, he was referred to a clinical genetic service, and they identified this single mutation in OFD1, which is orofacial digital mutation. It's X-linked, and often in males, X-linked disorders like this actually tend to be lethal, but it obviously hasn't proven that way in this child. And it's also a published PCD gene. So we see OFD1 without syndromic features as well, but it confers a respiratory ciliopathy. And so after discovering this and recognizing that this might be a ciliopathy, they referred this young lad to us aged 8 to undergo further diagnostic testing and some imaging. So the next slide, please. And the first thing we did was do a chest X-ray, which you can see on the right. And you can see that that left lung is completely white. So it looks like it's solid and probably collapsed down with very little air, very little ventilation. So this would explain why he had such erratic, often rapid breathing and problems with his symptoms. On the left is his brain scan, and this actually is a very typical finding. You can see in the middle there, because it's not my presentation, I don't think I can show, but there's a right in the middle of his brain, you can see that molar tooth shaped defect that's called the molar tooth sign, which is typical of one of the syndromes. Exactly right, thank you, called Joubert's syndrome, and OFD1 can also be associated with Joubert's. Next slide. We went on to do a CT scan, and we saw that in this child he had a really densely consolidated, so his left lung was collapsed right down, and you can see at the front there on the left-hand image that the lung is sort of herniating across the midline to compensate, and the heart has been pulled across as well by the collapsed lung, and there's very little ventilation. Next slide. And when you look at that in what we call a coronal section, so you're looking at it more like an X-ray, if you like, you can see that there's the large airways have some air, but they're not ventilating down into the peripheral airways. So that lung is effectively not being used. On the right-hand image, that's a bronchogram style of imaging, and you can see that there's sort of quite varicose-looking changes in the peripheral airways. That's a condition called bronchiectasis or scarring, and that's very typical of primary ciliary dyskinesia. Next slide, please. So the first thing we do with these, and you might have to click on the videos for these to show just at the bottom of each of those. Are these videos going to work? Yes, hopefully they will. So hopefully you can see that. But this is we take a nasal brush biopsy. So I showed you what the healthy cilia should look like in a healthy control. And on the right is another picture of a patient with normal respiratory cilia. I don't know if you can get that to work again. So they should look synchronized and motile. On the left, you can see, if you run that video again, you can see that they are motile, so they're not static like a classical case of primary ciliary dyskinesia, but these cilia are really quite abnormal looking. They're not synchronized, and some of the cilia are quite long, and some have these inclusion bodies, what we call bulbous tips. If you go on to the next slide, I'll show you some other images of that. You can get those videos to run. Hopefully you can get the impression that they're really quite abnormal looking, and the one on the left as well should be, again, more normal. And then when you go down and to the next slide, you can see the appearance on electron microscopy. So this is not a video, but that huge bulbous tip, we would call that, inclusion body, has fragments of microtubular debris, if you like, and it accumulates in there. So this is a transport problem within the cilia. So the components are being sort of built up and either not being degraded or not being transported properly. If you look at the small cross sections to the right of that bulbous tip, so you can see the small round images there, that is a normal cross section of a cilia. So you can see how enlarged that is. And then if you go down to the next slide, you can see there on the right that another very distinctive bulbous tip, but you can also see how long some of those cilia are. So see the very long cross section, much longer. So you get these long whip-like cilia that are motile but don't actually effectively clear secretions out of the lungs. So these are motile. Oh, can you still hear me?
Yes.
Yes, okay, sorry, it keeps blacking out this end. So these are motile cilia, but they're not effectively clearing mucus out of the airways. Next slide. We then apply immunofluorescent antibody staining, and you can see we're using an antibody called IFT88, which we use for intraflagellar transport issues. So if we've got a concern where we see bulbous tips or these very long cilia, we then use this particular antibody to see whether there is accumulation of all of those debris, if you like, in those inclusion bodies. So this type of staining is in the top left. The way we go about this is we use a nuclear stain to see that we've got a viable cell, and that's the blue stain called DAPI. On the top right is a green stain, which shows us that this is a ciliated cell, because there's no point applying antibody stains if you don't have cilia there. And so that's called acetylated tubulin. So we've got a good viable cell for using this type of diagnostic test. Bottom left, protein IFT88, and you can see where you get those very dense red circles and on the surface of the cell. So those are in accumulating stain in the bulbous tips, but also you get it, and I can't use the pointer, but you can see just at the surface of the cells there's an accumulation of stain as well where the basal bodies are. And then when you merge the two, top left and bottom left and top right, you get these sort of amber inclusion bodies. And then if you go to the next slide, I put this one in because we used a different type of antibody to look at the proteins within the cilia. And you can see this is the normal cilia, but you can see here, I hope, in the bottom right, in amber, this very, very long cilia, really abnormal. And we see quite a lot of those on the surface of patients with respiratory ciliopathies and patients with Bardet-Biedl, Joubert's, and other types of primary ciliopathy. Next slide. We always send these cases on our diagnostic pathway to the cell culture, so we can regenerate ciliated epithelium in a cell culture laboratory, and then we can re-examine them using beat pattern analysis and other imaging techniques. So these videos should play. If you just click on that, this is from the top view, but can you see just really at sort of between 10 and 2 o'clock at the top there, really quite a dense, high density of these sort of paddle-like inclusion bodies. That's very abnormal. And we find these changes in respiratory ciliopathies related to primary ciliopathies exaggerated in cell culture. And then the one on the bottom video should show you how long these cilia can be. So you have the inclusion bodies, but you also have the long whip-like cilia. And then next slide. That's a case of, I put this one in. You can see the normal ciliary axoneme in that huge dilated bulbous tip. So that very typical, just at 2 o'clock in that particular expanded bulbous tip, and then you can see the bits of microtubule in that inclusion body. So very dramatic changes. And when we see this, we would admit these patients into our PCD clinic, because the clinical presentation is very similar and they respond to the same sort of management, which I'll go on and describe briefly. So next slide, please. So for this patient, we had an OFD1 mutation in a syndromic patient with a brain scan that would confirm that this is a case of Joubert's. This mutation is often lethal, actually, in boys because it's X-linked, but it also results in a respiratory ciliopathy with a PCD phenotype. So it's the same picture as PCD, this difficulty of retained secretions because the airway clearance is not happening because of the dysfunction of the cilia. And one of the interesting things about these cases, next slide, sorry, is that when we see some of these respiratory ciliopathies in combination with a syndromic ciliopathy, sometimes the syndromic features are ameliorated, if you like. So they're not as fully expressed as you might see in other patients with Joubert's, or we've got a family with a very rare ciliopathy called Sensenbrenner with 3 children affected. And they have definitely got the typical syndromic features, but they're much milder and they're not as complete as the full-blown Sensenbrenner syndrome, which is something that we would like to understand a little bit more about. Next slide, please. So the management of respiratory ciliopathies is, in actual fact, pretty much identical to what we would do with primary ciliary dyskinesia. So Phil and his colleagues and other specialists who look after primary ciliopathies, if they have respiratory symptoms, would send them across for that diagnostic pathway that I've just walked you through. If we find that they've got those abnormal cilia findings and they have a clinical picture of PCD, we would admit them into the PCD clinic, and then we would have a shared care arrangement with the specialists looking after them, such as in the BBS clinic. And when they get into our clinic, the focus is about how do we manage their airway clearance. So the retention of secretions leads to recurrent infection and then scarring in the lungs. So airway clearance is an absolute key for these patients. So getting them onto physiotherapy routines, they might need nebulized hypertonic saline to help. It's what we call a mucolytic. So it helps break down the sort of tenacious mucus and allows patients to more easily cough that up. And also by giving them something like hypertonic saline, it makes them cough. So it's quite difficult to get children to cough, but if you give them a nebulizer that makes them cough and makes the secretions more liquid, a very effective way of helping them clear their airways. Increased risk of infection. Any patient that has a problem with their cilia, whether it's primary or secondary, tends to accumulate secretions in the lungs, and those that's a perfect environment for bugs to set up home, cause infection, and actually makes it much more difficult to treat, because normally when you're treating an infection in someone with functional cilia, you've got the antibiotics and your cilia are helping clear out the infected secretions. But when your cilia are not helping clear out infected secretions, we have to have a bit more of an aggressive approach to how we treat infections, so more prolonged courses of antibiotics, sometimes need intravenous antibiotics. And but it's very important that we're monitoring and screening patients for infection, so doing swabs and sputum cultures and making sure that we're not letting infections take hold. And then there are often a lot of ENT type symptoms, so rhinitis for older children and adults, sinusitis, glue ear, because the middle ears are drained via the eustachian tubes, which are lined with cilia, and if they're not working, that can cause obviously middle ear disease. And more common, if they have a primary ciliopathy, is obstructive sleep apnea, and that's partly because of the rhinitis and nasal congestion, but also the coexistent obesity in many patients with primary ciliopathies, which in itself can be a cause of obstructive sleep apnea. And so lots of patients would be referred for sleep studies, and do they need some form of non-invasive ventilation, so a mask ventilator that just helps overcome their obstructive sleep apnea. And that might be part of their syndromic features without a respiratory ciliopathy, if that makes sense. But if they also have a respiratory ciliopathy, then they're more prone to having more severe obstructive sleep apnea. And so we monitor for that with sleep studies and managing their non-invasive ventilation if they require it. So it's a very much an MDT approach. It's really important for us, actually, that we're sharing care with the specialist primary ciliopathy services, obviously, because they would then look after all of the other complex needs of these patients. Next slide. So there's still much to learn. PCD, and I haven't put this in here, but we are just starting our first mRNA gene-based trials at the Brompton for that, which is very exciting, actually. And as Phil has already said, you know, this area has just exploded in terms of gene therapies. So there is a lot to be optimistic about. In terms of the respiratory illness within the primary ciliopathies, we see, we've actually published on this, but one of my team, Amelia Schumacher, went into Phil's clinic and was screening patients there in the early days of the commission service. And we found that around 15% of patients in that clinic had a respiratory ciliopathy. But the team there are really, really good at referring the patients across, and we can do the tests, we can check for obstructive sleep apnea. And if they need either non-invasive ventilation or they need PCV type management for their respiratory ciliopathy, then we can enter into shared care. What's really interesting to us is that they present and have the same functional clinical picture. The defect in their cilia creates the same clinical picture, but the diagnostic findings are so very different between primary ciliary dyskinesia and the primary ciliopathies, and we're not sure why that is, why they have such a different, you know, we don't see those inclusion bodies in very long cilia in primary ciliary dyskinesia. But they should all be investigated and managed as though they did have, you know, effectively what I'm trying to say is that primary ciliary dyskinesia is just one of a wider group of respiratory ciliopathies, and that those respiratory ciliopathies include those particular findings that I've shown you today from the case with Joubert's. And I think my last slide is just acknowledging the team that have been working in this sort of combined way to try and learn a little bit more and try and streamline some of the pathways for these patients to make it easier for them to get the care they need. So thank you very much.
Thanks so much, Claire. I know many of us have experienced the impact of Cilio on the respiratory system in BBS as parents or patients, and how difficult it can be to have it properly managed and understood at a local level.